For 20 years, orthopedic research into knee osteoarthritis produced a confusing dataset. One study showed dramatic recovery, the next showed no difference from saline. This variability wasn't a failure of the target tissue, it was a failure of the biologic product. Different PRP systems were delivering wildly different platelet concentrations while using the exact same clinical label. Berrigan's 2025 analysis identifies the source of this variance. In positive outcome studies, the mean dose was approximately 5.5 billion platelets. In failed studies, the dose dropped to 2.3 billion. In indications like lateral epicondylitis, platelet concentration alone explains over 58% of the heterogeneity. Low-dose systems fail to reach the minimum biological threshold required for a response. Doses at or above the 5 billion mark align with the measurable clinical efficacy observed in high-performing trials. Hitting that volume threshold is only the first requirement. The specific formulation of those cells determines the subsequent inflammatory response inside the patient. Orthopedics offers a binary choice. Left, leukocyte-poor PRP, a clean plasma environment. Right, leukocyte-rich PRP, an inflammatory environment with white cells. Leukocyte-poor is standard for closed joints and chronic tendinopathies, minimizing adverse events. Leukocyte-rich serves a narrow niche for acute muscle and gluteal tendinopathy. To safely treat the majority of standard orthopedic indications, a clinic's biologic engine must default to producing a leukocyte-poor formulation. Moving inside the intra-articular environment, the knee provides the most robust evidence base for this leukocyte-poor protocol. Against hyaluronic acid, PRP delivers a 44.7% improvement on the Walmach osteoarthritis scale, compared to HA's 12.6%. This performance led ESCA to classify PRP as a valid first-line injectable treatment option. When treating smaller capsules like the CMC joint in the thumb, the ankle, or the wrist, the physical mechanics change. These joints cannot tolerate large injection volumes, demanding a highly concentrated output to hit the required cellular dose within a small syringe. For adhesive capsulitis, frozen shoulder, the data is consistently positive. PRP achieves high statistical p-scores for pain reduction over 12 weeks, performing significantly better than corticosteroid injections in meta-analyses. The hip requires clinical transparency. While studies show moderate evidence for improvement, multiple double-blind trials show no significant difference between PRP and saline placebos. The joint's depth and structure temper the expected outcomes. Across closed joint capsules, a high-dose, low-volume leukocyte-poor protocol consistently outperforms synthetic lubricants and traditional steroid injections. This graph tracks pain relief over time in peritendinous environments. Corticosteroids deliver a sharp early spike in relief, but quickly crash, often dropping below the patient's baseline. PRP follows a different trajectory, building a gradual, steady climb to sustained recovery. In both lateral epicondylitis and plantar fasciitis, the data clearly separates at 6 months. Steroids mask pain initially, but PRP sustains relief through 12 months, meeting the threshold for minimal clinically important difference. For chronic Achilles tendinopathy, avoiding further inflammation is critical. Using strictly leukocyte-poor PRP yields a 72%. Clinics are shifting away from temporarily managing symptoms with steroids toward modifying the underlying disease with orthobiologics. Moving from the outpatient clinic into the operating room, orthobiologics take on a mechanical role in structural tissue repair. In rotator cuff repairs, leukocyte-poor PRP is activated into a gel. This creates a physical fibrin scaffold exactly at the bone-tendon interface, a biological matrix that actively drives down re-tear rates. We see similar structural reinforcement in meniscal repairs. Adding a biologic augmentation cuts the surgical failure rate by more than half, dropping it from 25.7% down to just 9.9%. There is a strict clinical distinction here. PRP only augments structural repairs involving sutures. If the procedure is a partial meniscectomy, the removal of tissue, the biologic provides no recovery benefit. In the surgical suite, PRP functions as an active structural biomaterial, physically reinforcing the repair site to alter surgical survival rates. This capacity for tissue recovery has driven widespread adoption in elite athletics. Global anti-doping agencies have cleared its use since 2011. High-profile recoveries from athletes like Tiger Woods brought early attention to these biological protocols. In the NFL, data on acute hamstring injuries shows that athletes treated with leukocyte-poor PRP returned to play 8.6 days faster, resulting in 1.6 fewer missed games. Achieving those numbers requires a strict chronological protocol. The biologic must be injected within 24 to 48 hours of the acute injury and immediately paired with structured, sport-specific rehabilitation. In elite sports medicine, time is the primary constraint. Immediate, precise orthobiologic intervention buys it back. When dealing with massive structural deficits, however, clinical expectations must be managed carefully. For ACL reconstruction, injecting PRP offers transient, short-term pain relief, but long-term data shows it provides no benefit for functional outcomes or MRI graft maturation. In cartilage repair and microfracture augmentation, there is an emerging positive signal for tissue stability at 24 months, but the evidence is not yet a universal standard of care. A biologically responsible protocol recognizes these limits. PRP acts as a catalyst for native tissue, but it cannot single-handedly overcome major structural deficits. The scientific requirement is clear. Clinicians must deliver a high platelet dose alongside concentrated proteins, packaged in a low physical volume. The PCX ultrafiltration system avoids the destructive second centrifuge spin. Plasma pushes through a 15 kilodalton membrane, trapping therapeutic elements while excess water escapes. This transforms a 24 milliliter blood draw into a 3 to 4 milliliter output, matching the mechanical capacities of small joints and tendons. This ultrafiltration enables a second axis of therapy. Legacy double-spin systems discard critical plasma proteins. PCX concentrates them, retaining master protease inhibitors like alpha-2 macroglobulin for joints and fibrinogen for surgical scaffolds. All specific PCX performance figures discussed here are design-based projections pending formal clinical validation. PCX is engineered specifically to meet the physical and biological constraints of the orthopedic joint. Across 559 studies representing over 76,000 patients, the serious adverse event rate for PRP registers at just 0.3%. Its 8.7% overall adverse event rate makes it the safest injectable intervention currently available, performing better than both hyaluronic acid and corticosteroids. This safety profile exists because the product is autologous. Utilizing the patient's own blood eliminates the risk of immune rejection or complex pharmaceutical interactions. The risk-reward ratio of a properly formulated orthobiologic compares favorably to conventional pharmaceutical management. With over 119 randomized controlled trials for knee osteoarthritis alone, PRP is now a validated first-line injectable treatment option. But that clinical validity relies on scientific precision. Clinicians must deliver an adequate platelet dose, preserved cellular viability, and concentrated plasma proteins, all contained within a tissue-appropriate volume. The PCX by Swiss Concept provides the mechanical instrument designed to meet these exact clinical specifications. The future of orthopedics relies on recovering, concentrating, and deploying the complete regenerative profile of the patient's own blood.